So there's a systematic analysis done of the available literature, and some 23 trials are included, nearly 6,000 patients. Most of them were about 60% or so PD-1 inhibitor treated, and the others PD-L1 inhibitor treated. And the findings with that was, first of all, that the response rate was very, very similar, pretty much identical. And then the issues about the toxicity, which is of particular interest here. The overall toxicity was very, very similar. And the similar sorts of toxicities as well. And what we saw in terms of there was increased incidence of immune-related adverse events with the PD-1 inhibitors, but when you looked at more severe toxicities were a bit more common with the PD-L1 inhibitors. So I think the overall message from this is that the toxicity profile in terms of toxicity is low. And that given the retrospective nature of this analysis and systematic review type process, that really these such small differences are really probably not significant, and that essentially from the toxicity and from the response rate point of view, the PD-1 and PD-L1 inhibitors as classes basically are very, very similar.
You were telling me also that some of the fatigue data that were collected showed an importance of that perhaps is not fully appreciated in using these drugs?
One of the issues about these drugs is that we treat patients for long periods of time, and even mild side effects like fatigue can be quite troublesome in their everyday life, and so that even the grade 1 fatigue can significantly interfere with their daily activities. Now, that's not so bad if you're only treating for a patient for 3 or 4 months on chemotherapy, but if you're treating for 2 years on an immunotherapy, it becomes quite an important factor. And so I think in general the field is noticing now that the fatigue issue is something that's important. Probably around about a quarter of patients, maybe 30% of patients have noticeable fatigue. And really across the PD-L1, PD-1 inhibitors is much the same.
So given the similar toxicity profiles, and also efficacy was looked at briefly in this analysis, and that also seemed to be pretty similar, are there any criteria you could see that perhaps a clinician can use in deciding which of these agents to use for a particular patient?
Yeah, well, in the second line setting anyway, the first line setting is somewhat different. Is that really it's the PD-L1 high tumour patients that currently in the current literature should be treated. But in the second line setting, you have 3 options essentially. For PD-L1 positive tumour patient, then pembrolizumab is an option. The nivolumab and the atezolizumab are options in a PD-L1 sort of unselected, or where you don't have a value for that patient's tumour. In terms of selection across in terms of selecting these, well, essentially the toxicity, according to the systematic analysis, and also our own centre, our experience, we've used all of these drugs, are pretty much very, very similar in terms of toxicities. So the other issues might be around availability in terms of whether these are reimbursed by a third party or not. There might be issues of patients having to have out-of-pocket expenses or pay for these drugs in terms of the cost. And then there's a convenience factor also in terms of how frequently these things are being administered. Nivolumab in general is given every 2 weeks, which is more frequent than some of the other agents, but I know there are trials which are looking at whether it can be given less frequently.